Welcome to today's clinical meeting. We'll start with our first presentation from Medicine 1, presented by Dr. Dorene, the poison pulse.
This is regarding one of rare case reports which we had come across during in our toxicology among our toxicology patients. The poison pulse. So he's Mr. M. He was a 71-year-old farmer who had presented with complaints of ingestion of 65 ml of profenophos and cypermethrin on 27th of August at around 6 p.m. Post which he had complaints of excessive salivation and 2 episodes of vomiting. He did not have any diaphoresis, lacrimation, enuresis, defecation, or dyspnea. No history of a drooping of neck or muscle weakness at presentation. No history of any prior self-harm attempts. And he's all comorbidities wise, he's a known case of diabetes and hypertension for 3 years, has been on regular medications from the government hospital. He had no history of any prior known cardiac disease. On examination, when he had presented to us, his pulse rate was 160 per minute, irregularly irregular, with a blood pressure of 130 by 80, respiratory rate of 26, and saturation 94% on room air. General examination, there was no pallor icterus of pedal edema, no elevated JVP, peripheral pulses were palpable. His neck holding time was more than 30 seconds, and his single breath count was 21. Systemic examination, he was noted to have bilateral, very minimal crepitations heard in the infrascapular region. First and second heart sound was normal. There was no murmurs that was noted. Abdomen was soft and non-tender. There was no organomegaly. Pupils were equal, reactive, and there was no focal deficits that was noted. His initial preliminary investigations, his cholinesterase levels at the time of presentation was 248, which was significantly low. Electrolytes, he was noted to have a mild hypokalemia, 3.3. His ABG, his PCO2 was 27 and PO2 was 71. There was no carbon dioxide retention. And this was his ECG at the time of presentation. As you can see, his waveforms are pulses irregular and irregularly irregular, and there was no P waves. He was noted to be in AF at the time of presentation, which was considerably odd considering the amount of organophosphorus that he had ingested. He was expected to be having a more in bradycardia. So in this situation, so as we all know, so as the syndrome that he has presented with is acute cholinergic crisis with the paroxysmal atrial fibrillation. The ideal next step would have been atropine. So in this case, we all know that atropine has a propensity to worsen the atrial fibrillation. So the questions that was initially asked when this gentleman had presented was, is it safe to administer atropine in atrial fibrillation? If so, which should be addressed first? Any opinions?
Okay, there are only 10 of us here, so it's like a unit clinical meeting. So no one needs to feel inhibited. Does anyone have any opinions? Reshna, will you give atropine to this patient? Yes or no? Okay, let's say show of hands. Who will give atropine? You can put up your hands if you'll give atropine to this patient. Who will definitely not want to give atropine? Okay, Thomas says no. I also would definitely be very hesitant to give atropine. Dorene, what do you think? Yeah.
So this was the initial confusion that we had when this patient had presented to our emergency department. So coming to my presentation, the atrial fibrillation, which is a rare arrhythmia which is noted in OP poisoning. So the common cardiovascular effects that we commonly notice in a patient with organophosphorus poisoning is they can have hypotension or hypertension, bradycardia, pulmonary edema, QTC prolongation, arrhythmias, and myocardial ischemia being on the rarer end. The mechanism of the cardiovascular toxicity in organophosphorus, it has 3 phases that has been described. The first phase is a brief period of sympathetic overactivity, which can explain a tachycardia and hypertension, which is due to an excessive release of catecholamines. Coming to the second phase is when which is a predominant phase where there is a parasympathetic overactivity causing the cholinergic excess, and just the common symptoms that we notice are bradycardia and hypertension. or it can also sometimes predispose to life-threatening arrhythmias. The third phase is a much more critical phase, which can result in sudden death, such as a prolonged QT interval with a polymorphic VT, such as a torsades. Coming to atrial fibrillation in organophosphorus particular, it is noted in almost less than 5% of the cases, and it is generally noted in severe organophosphorus ingestion. The pathogenesis that has been explained in the few rarer case reports so far is that the organophosphorus per se can cause direct myocardial toxicity and resultant disturbances with the electrolyte homeostasis, or it can also alter the action potentials, disrupting the calcium and potassium channels and precipitating an atrial fibrillation. The atrial fibrillation is likely to be a paroxysmal or in a rare event persistent, but never a chronic one. It resolves with the resolution of the toxicity. And it has also been noted in case reports that it is commonly noted in patients with combined poisoning, such as an organophosphorus along with the pyrethroid, such as the event in our patient. So there are very few case reports that has been documented of an atrial fibrillation in an organophosphorus poisoning. So these were a few of the case reports that we had referred to prior to in regards to this case management. So the common management that has been described among all these case reports is that first, the line of management will be the stabilization of the hemodynamic parameters. All of these patients were started on atropine or palidoxin, and there is no role of withholding atropine in an atrial fibrillation. The management of atrial fibrillation per se will again be the same along with rate controllers like beta blockers, calcium channel blockade, amiodarone, or if in the case of an unstable atrial fibrillation, the patient can also be DC cardioversion can be done. And in all of those case reports that we had documented, it was noted that the rhythm was reverted to sinus in all of the case reports. And they had also followed up the patients at a later date, and they had done an echocardiography, and a normal structural heart was also documented. Coming to our patient, he was treated with atropine boluses, but after trombonization, and he started on infusion. We had given him metoprolol 2.5 mg IV, with which his rate had controlled and sinus rhythm was documented. He had no further atrial fibrillation during the course of his stay in the ward. A formal echo is still pending for this gentleman. The learning point that we had from managing this case was that there is no contraindication for atropine when the patient has an atrial fibrillation, and the presence of the possibility of an atrial fibrillation even in a patient with an OP poisoning.
Sure. Thank you, Doreen. Does anyone have any comments or questions? I thought one thing is that, so when you put out your clinical history, you should put your clinical diagnosis before you give any investigations, meaning an AF can be diagnosed clinically as well. So an irregular pulse with tachycardia, that itself can tell you that it's atrial fibrillation. And then the other thing is, to call it paroxysmal atrial fibrillation, you have to see that it has resolved. And you also have to assume that it wasn't there earlier. So when you see the patient, you don't know if this is a chronic atrial fibrillation that has now gone into a fast ventricular rate, if it's going to be a permanent atrial fibrillation. So you can't really say that it's paroxysmal, or you can only retrospectively say that it's paroxysmal. You're assuming it is. The other thing is, most patients who come with OP poisoning tend to have been seen in another hospital and gotten some treatment. So was it giving atropine that precipitated this AF? He probably has multiple risk factors: his age, comorbidities, the OP poisoning itself. And did he get atropine somewhere? Because I think it's not very common for patients to come to CMC as the first place they go. It's a tertiary hospital, it's a referral hospital. So maybe he got a bolus of atropine already, which I think slightly increases the risk. Nice to know. Good to know that you should manage probably both simultaneously, basically, right? Yeah. Okay. Any comments? Medicine one. Amit, any comments? Okay. Thanks.